people are coming in, and again, there's chairs down here. I'm Judy Noodleman, and I'm a member of the Wellness Committee. And it's my pleasure to introduce Dr. Charles Nemeroff this evening. Dr. Nemeroff is chair and professor with Dell Medical School Department of Psychiatry and Behavioral Sciences. He is co-director of the Charmaine and Gordon McGill Center for Psychedelic Research and Therapy and directs the Department of Psychiatry Institute for Early Life Adversity Research. We are so honored that he has added us to his busy schedule to share his expertise in mood disorders, anxiety, and depression. It can help each of us better understand how we can enhance our well-being. Prior to joining Dell Medical School, he served as chair of psychiatry and clinical director of the Center on Aging at the University of Miami Miller School of Medicine. He received his medical degree and doctorate degree in neurobiology from the University of North Carolina School of Medicine, and then held faculty positions at Duke and Emory. Dr. Nemeroff has served as president of the American College of Psychiatrists and American College of Neuropsychopharmacology. He sits on the advisory board of the Brain and Behavioral Research Foundation and is past president and a board member of the Anxiety and Depression Association of America. I could continue with many more accomplishments and awards for Dr. Nemeroff, but you're more interested in hearing from him, so I won't. But a few housekeeping items before we welcome him. 1, please silence or turn off your cell phones. 2, please hold your questions till the end of the session when we will have microphones floating through the audience. And lastly, he's here to answer your questions, but he's not here to serve as your personal psychiatrist. So with that, join me in welcoming Dr. Nemeroff to Westminster.
Well, thank you, Judy. It's a pleasure to be here. It's a great turnout. I changed the title of my talk, which was depressing. I thought I might put some people off by this. I am going to talk a little bit about depression in the elder age group, but I really wanted to talk about aging in general and try to dispel some myths about aging, and I'm more than happy to answer questions as we go along. I did want to say that one of the reasons I've been moderately successful is that I have a great wife who keeps me grounded. And when maybe the best honor that was ever bestowed on me was being elected to the National Academy of Medicine, which is a very elite group. There are only about 50 psychiatrists in the United States elected to that. And so I was at the Ritz-Carlton in Washington, D.C., putting my tuxedo on, and I said to my wife, in your wildest dreams, did you ever think I would be elected to the National Academy? And she looked at me and said, you're not in my wildest dreams. This is just my financial disclosures. I serve on a number of scientific advisory boards of various companies, but my research is supported by the National Institute of Health. So I want to sort of give you an overview about population aging, about sort of myths about aging and realities about aging, and then talk about promoting what I would call successful aging. So we, because I'm in your group, we are increasing in numbers in the United States, and you can see here the number of individuals in millions that we will achieve by the year 2030. That's a sizable number, and incidentally, all of us ought to vote. as an aside, you understand what I'm saying, right? Our votes count. You can also see that as you look at the population in millions that are going to over the next 30 years, you can see that the 85 and over group is really going to substantially climb. And by 2050, we'll reach 20 million, and the 65 and over group will reach almost 90 million. That's a very big number. So very different from when I was born back here. You can see those numbers where very few people live to be over 85. And so part of that happens to do with the miracles of modern medicine. And when I was in medical school, there were many disorders that we were unable to treat. When I was in medical school, the mean survival time for breast cancer was 5 years, and now it's 40 years, right? So we've really made remarkable advances. If you look here at 90 and over, right, which I personally aspire to, you can see that this is going to substantially increase between where we are now, which is about 4 million, to by 2050, this will be more than double. And this has to do with the quality of health care that we can provide to individuals, and the fact that we've learned a lot about exercise, diet, and healthy living. So there, with more longevity, and it's a whole area of research I'm not going to talk about today, but longevity is a very active avenue of research, the idea about how one can lengthen one's lifetime. But what this means with living longer is there are a lot of opportunities. Opportunities for work and productive engagement, family support, education and training, but there are also challenges related to health care. I always tell my patients that none of us are going to get out of this life alive, and all of us are vulnerable to something. Some of us are vulnerable to diabetes, some to depression, some to Alzheimer's disease, but we can certainly try to manage those conditions to the best of our ability. So let's talk about the myths about aging. So older people are all alike. No, they're not. Old people are by definition sick. No, they're not. Older people are all depressed and they're not interested in any activity. No, that's not true. Many older people live in institutions. No, they don't. The worst one, you can't teach an old dog new tricks. Yes, I have an old dog and I could teach him new tricks. Older people are technophobic. No, you all have iPhones or the equivalent. I know you do. And then the secret to successful aging is choose your parents wisely. That's only true related to genetics. And we'll talk a little bit about genetics. Because you know what? You don't pick your parents. The quote elderly age group now, all of us are better educated, more diverse, healthier, and more active than previous generations. I don't know about you all, but my parents didn't exercise. I mean, if I had said to my parents, like, why aren't you exercising? They would, what are you talking about, right? It just wasn't in their wheelhouse. And many individuals our age are involved in full or part-time work or volunteer work and pursue new hobbies, and many are involved in caregiving. There are older workers that are doing pretty well. They're also very rich, right? But they're doing pretty well. I mean, Mick Jagger can still do it. And we were talking about Herb Alpert before. So let's start with the fact that aging is associated with a very large variability, right? The so-called aged population is incredibly heterogeneous. And you know that from people that you know in this age group. But aging is associated with plasticity, meaning that you can engage in new learning. And in fact, the adult brain is making new nerve cells, neurons, all the time, particularly in the hippocampus, which is the brain region most associated with learning and memory. And there was a remarkable experiment done years ago where these investigators wanted to demonstrate that old people can make new neurons. And in order to do that, you have to take a radioisotope, and then when you die, you have to donate your brain. And so a group of women with metastatic breast cancer enrolled in this experiment. And after they died, their brains were harvested and examined, and it was the absolute clear demonstration that old brains, even approaching death, make new neurons. And making new neurons means that you're capable of learning, which is important and dispels a number of old myths. Now, there are changes that occur with aging. One of them are changes in vision and audition. I'm wearing hearing aids. I should not have listened to all of that Led Zeppelin and Grateful Dead, and now it's catching up to me. And there are changes in mobility, strength, response time. There are issues related to balance as we age. I'm an avid fly fisherman. I have to be pretty careful when I'm standing in the river because my balance isn't what it used to be. And I have a personal trainer that comes to my home every Sunday and tortures me in order for me to maintain some level of physical strength and balance. And of course, there are certain medical conditions associated with aging, such as arthritis. And I have a little osteoarthritis in my finger here. Not much I can do about it. And of course, we worry about cardiovascular disease, heart disease, and cerebrovascular disease. So as we age, there's more difficulty with certain routine activities that, you know, one of the things I always wonder is those blister packs of pills. They're almost impossible to open. Right? Why do they do that to us? You know? So I mentioned the sensory changes that we experience, the changes in balance. We have slower reaction times. We move a bit slower, and there is, and I'll talk about this in more detail, some decline in cognition. Now, you might wonder, why is it that there are no 50 or 60-year-old tennis players or golfers in terms of professionals? Why is it that Roger Federer had to step down from the tour? I mean, obviously he was fantastic. And why did Jack Nicklaus and Arnold Palmer, why did their game sort of decline over time? So the neurotransmitter in the brain that is most concerned with movement is dopamine. And that is the neurotransmitter that declines in Parkinson's disease. And it's why people have a slowness of movement. Well, this is a study that was measuring dopamine function as a function of age. And the more dopamine neurons you have, the more you're likely to be able to return a tennis ball, hit a really long golf shot, et cetera, et cetera. And I was on my high school baseball team. I was pretty good. When I was 50, I went to the Atlanta Braves fantasy camp, caught 48 innings, which I was very proud of. Last year, in the resident faculty softball game, I couldn't hit a damn softball. Okay, pitiful, right? I could see it, but I just couldn't get around it. Why is that? Well, it's because I'm out here and look at this measure of dopamine neurons. The top line are healthy people, and you can see that we all lose dopamine neurons over time. And sometimes we say that we're getting Parkinsonian, but we don't have Parkinson's disease. You know, I was talking to somebody the other day, and they said to me, well, you know, if you have to, you can run. And I said, run? I don't run, okay? The only time I'm going to run is if I'm in Alaska fly fishing and a bear comes along. And then I only have to outrun my buddy, right? But we can't fix this, right? I can't give Roger Federer anything that's going to allow him to have the reaction time that he had when he was in his prime. And all of us deal with this. So if you look at impairment of vision and hearing, you can see that as we get to, say, 75 years of age, more than 50% of people have a little arthritis. I only have it in my fingers where I broke them playing football, but it's very common. That's not rheumatoid arthritis, that's osteoarthritis, which is what we suffer with as we get older. And then you see hearing loss occurs in, you know, about 35% of people 75 and older. Vision, not as dramatic, but it does affect a substantial number of folks. Now, because I'm a geriatric psychiatrist, I take care of a lot of people who are in that age group, and they have a certain number of concurrent medical disorders. So if you look at people over age 65, you can see that this is divided up into men in, I don't know, what is that, magenta, and women in burgundy. And what you see is that men suffer higher rates of heart disease, but you see hypertension occurs in more than half of both men and women. Then there's stroke, a small number, 10%, asthma, chronic bronchitis or emphysema, cancer, about 20% of the population, diabetes, about the same, and here's arthritis, you can see. And unlike heart disease, women tend to be more susceptible to arthritis than men. So let's talk about depression. Let me remind you about what depression is. So depression is not being sad when the Longhorns didn't make it to the damn playoffs, okay? I was angry and upset, but I wasn't depressed. Depression is a syndrome that's characterized by a number of symptoms, which include disturbances of sleep, disturbances of appetite, crying spells, difficulty concentrating, thoughts about life not being worth living anymore. We'll talk about that some more. This is, like other diseases, a complex disease that is partly driven by genetics and partly driven by life circumstance. So these are the rates of depression as a function of age, and you can see that in the 85 and older group, about a fifth of people have depression. Oh, thank you. So there is a syndrome called depressive pseudodementia, in which I evaluate patients, and they look for all the world like they have Alzheimer's disease, but they don't. They're so severely depressed that they're impaired in terms of their memory, their concentration, and one of the rule-outs in evaluating people with dementia is to make sure that they do not have a depression. And if you treat people for depression, their, quote, dementia goes away, and they come totally back to normal. All right, let's talk about the worst outcome of depression. The worst outcome of depression, and these are old slides because the numbers haven't changed at all. So understand that there are 51,000 reported suicides in the United States every year. There are probably twice that, but that's what we know about. Many individuals who commit suicide end up driving into a tree, single car accident, and it's not reported as a suicide. Let me just get these numbers out there. That's the important number, which is the increase in suicide in the 85 and older group. You can see the 65 to 84 age group as well. And then you see something rather interesting here, which is at this time in the studies, we noticed a remarkably interesting finding, which is the suicide rate in the 45 to 64 age group surpassed that of the elderly. So when I was in medical school, we were told that who is at the greatest risk for suicide? White men who own guns, particularly after they lose their spouse, are at the highest risk for suicide. This is totally flipped to now the 45 to 64 age group has surpassed suicide. One of the remarkable findings in the suicide literature is that white people, particularly men, are at the greatest risk for suicide. Remarkably, African Americans and Hispanics have the lowest rate of suicide, as do Asian and Pacific Islanders. The two highest suicide groups are Caucasians and American Indians. American Indians partly confounded by the very high rate of comorbid alcohol abuse in that population. But this is what really stands out, is the remarkable difference in suicide rates between men and women. So women, thankfully, are really bad at it. They actually have as many suicide attempts as men, but they take 4 Tylenol and then call 911. Men engage in violent suicide. I had a patient last week try to hang himself with a belt and was found, fortunately, by his wife and was cut down. A little graphic, but this was a patient who showed up at the Massachusetts General Hospital emergency room with a small scab on his forehead, and he admitted to taking a Black & Decker nail gun and putting it to his head, and there you can see the nail right there. And he survived. The good news, they didn't put him in an MRI. Because if they did, the magnet would have ripped the nail and it would have killed him for sure. So good thing you mentioned that he survived. So these are the methods of suicide, and the #1 cause of suicide is untreated depression. Right? So depressed patients fundamentally say, I'm a burden on my family, I'm hopeless that I'm ever going to feel better, I'm helpless to do anything about it, every moment that I'm awake is painful, I have no joy in life, nothing that I used to enjoy do I enjoy, and then they decide to put an end to it. I've treated many patients who were suicidal and committed many against their will. No one ever became angry with me later. They were really pissed off when I committed them to a psych hospital, but after they were treated and got better, they thanked me because depression is a treatable illness. There's no question about it. So firearms is a big problem. The availability of a way to kill yourself, if you put an obstacle in front of that, you reduce suicide rates. Best example, the Golden Gate Bridge. So the Golden Gate Bridge was a suicide mecca. And 10 years ago, a group of us got together and petitioned the San Francisco City Council to put nets under the Golden Gate Bridge. And there was this huge debate, oh, it's an eyesore. Oh, this is an icon for the city. No, we can't do that. Well, we did it, and the suicide rate has plummeted to 0. New Zealand did the same thing. We have a problem with firearms, right? Countries that have restricted firearms have very low rates of suicide. Guess where we live, right? It's a problem. And I can't tell you how many times I say to families, are there guns in the house? And the answer in Texas is always yes. Of course, well, are they locked? Are they in a gun cabinet? Can you get the gun out of the house? Don't bring them to my office. What are the triggering events? Obviously, a loss of social support. In the general population, humiliation, loss of a job, discovering that your spouse has been unfaithful, those kinds of activities. Developing a major health problem. So one of the biggest risk factors, I don't know, am I going to tell you about this or not? Let me see. I'm just checking to see if I brought this with me or not. Whether I'll tell you about it. Oh, I am. Okay, never mind. Fundamentally, once you have a loss of hope and you are unable to experience pleasure, you're going to be at risk to think, particularly if you start drinking. More than half of suicides has alcohol on board because it disinhibits you. There is a genetics of suicide in the same way there's a genetics of developing depression or other disorders. This is what's called a genogram, and this is a family that all of you know. This is the Hemingway family, right? So here's Ernest Hemingway, right there. And as you probably know, 3 weeks after being discharged from the Menninger Clinic in Topeka, Kansas, Ernest Hemingway put a shotgun in his mouth and killed himself. He also was a drinker. But look up here, his mother, Ursula, committed suicide. And his grandfather, Clarence, committed suicide. And his uncle, Leisler, committed suicide. And then if you look at his children, his granddaughter, Margot, committed suicide. I'm pretty good friends with his other granddaughter, Marielle, who has suffered with depression but has not ever had a suicide attempt. That's a good example, and it's why we ask patients about their family history, not only for psychiatric disorders, but for suicide. So this is what I was going to mention to you. This has not been understood until relatively recently, but individuals who are given a cancer diagnosis, and sometimes the doctor who's giving you the diagnosis may not be the most psychologically sensitive person in the world. So most patients don't know what that means. You know, what does it mean? And many of them view it as a death sentence and view it as a way that they're going to be a burden to their families. So this study was done in the UK. I'm just going to spend a minute telling you about it. But they studied 4.2 million patients with cancer, half men and half women. And what they found out was that there were certain cancers that were associated with very high rates of suicide, like 4-fold increased risk for suicide. And those were cancers, what are called mesothelioma, pancreatic cancer, esophageal cancer, stomach cancer. So I became interested in this subject. And what we discovered about this is that the risk is all in the first 6 months, after the diagnosis. So the classic here is men with prostate cancer, right? So men get a diagnosis of prostate cancer. The urologist sits down with them and says, okay, you have prostate cancer and there are different ways to treat it. We can take out your prostate. You're never going to have an erection again. And you're also going to wear a diaper for a while. Okay, we'll see you next week. Most men are thinking, oh my God, this is part of who I was as a person. And now I'm losing my independence. I'm going to be a burden on my family. As an aside, there was a study done where they interviewed 100 men with prostate cancer and their wives. And 100% of the women said, I don't care if they take out his prostate and he's not able to be sexually competent. Who cares? I want my husband. Half of the men said, I'm not going with that treatment because I'm not willing to give that up, even if it means I'm going to die soon. Big difference between men and women. My wife would say it's because testosterone is a poison. It's not our fault, okay? So oncologists need to be aware of the fact you can't just walk in and say to somebody, oh, you have breast cancer, I'll schedule you with the surgeon and then we'll send you to MD Anderson. No, that's not the way to treat them. Now, depression also, because of the biology of depression, is associated with increased risk of heart disease. It increases your risk to develop heart disease, and it increases your risk to die if you have heart disease. This is one of the most replicated findings in all of American medicine. If you go to the American Heart Disease website, where they list the risk factors, which include cigarette smoking, alcohol abuse, family history, depression is right there with the others, right? So it's really important. Depression is very treatable, right? We're good at this. All of you know about Prozac and Zoloft and Effexor and all these antidepressants, and they work. We could pretty much remove depression in about 2/3 of people with depression, given a chance, if we can treat it. There are evidence-based psychotherapies to treat depression that are quite effective, and there are antidepressant medications. So I'm going to leave depression. That was depressing enough. And now we're going to talk a little bit about normative changes in aging, and then I'm looking forward to taking your questions. So cognition involves a whole bunch of different domains. That includes memory, attention, processing speed, spatial cognition. I was telling Judy I wasn't born with that quality. I get lost everywhere. I told her, you need to point me to where my car is. Okay. Problem solving, reasoning, and of course, this is quite apart from those individuals that might develop a dementing illness like Alzheimer's. So if you look at aging, one of the things you'll find rather interesting is that yes, there is a decline in perceptual speed. You know, have you tried to play a video game lately? I used to be really good at Pac-Man. I'm not good at Pac-Man. Spatial ability, working memory, memory and recall, they're all decreased. But look at verbal ability. You actually get better as you age until you get, you know, into your late 80s, and then you start seeing a decline. All right, well, let's at least talk about Alzheimer's disease. The biggest risk factor is age. And if you live to 85, you have a pretty high likelihood that you're going to develop Alzheimer's disease. There are treatments for Alzheimer's disease, newer treatments being developed all the time. They're very hard studies to do because you take patients with Alzheimer's disease and you give half of them the drug and the other half placebo, and then you just follow them over time. And what you want to find is that the people that get the drug decline at a slower rate. Those are very long and expensive studies. And we have a few treatments for this to help slow the progression. They're not great, but they're better than they're certainly better than placebo. We're learning more and more about the disease. What gets people into trouble in Alzheimer's disease is getting lost, walking out of your home and getting lost. You know, all those alerts that we get on our cell phones. Getting agitated, beating up your caregiver doesn't help. Okay, and that's what gets people more into memory care when they start being very agitated and difficult to manage. Alzheimer's disease has a particular pattern in the brain, which I'll show you in a second. And now we do have blood tests to actually help in the diagnosis of Alzheimer's disease. So the characteristic in the brain, a picture of Alzheimer's disease are called amyloid plaques, shown here, and then tangles, what are called neurofibrillary tangles in neurons. You don't want that. What's really interesting is about 15 to 18% of people that die without any symptoms of Alzheimer's disease have plaques and tangles in their brain. And no one knows why. If you just looked at the brain, you'd say this is Alzheimer's disease. So this is a very interesting group of people. They show no cognitive decline, but the brain is riddled with plaques and tangles. This is, just want to show you the hippocampus here, because it's the brain structure most effective in Alzheimer's disease. And so with aging, there's a little bit of change, but not much. But then look what happens if you develop sort of mild dementia, which is called minimal cognitive impairment. And then once you develop Alzheimer's disease, you're starting to see a loss of tissue. So mild cognitive impairment is literally sort of like, it's not that you can't remember where your keys or your phone are. To be clear about that, that's not what it is. It's showing some cognitive changes, but not having a full-blown Alzheimer's disease. And the important point is not everybody with minimal cognitive impairment actually develops Alzheimer's. There are a number of other conditions in which patients are thought to have had Alzheimer's disease and they don't. The leading cause of dementia, apart from Alzheimer's disease, is what's called vascular dementia. These are people that had hypertension their whole life, usually also have heart disease, but they're knocking off a number of their brain cells because they have many strokes. And if you look at their brain with an MRI scan, you can see these little sort of silent strokes that have occurred. In the old days, before we had those imaging, everybody in that group was called Alzheimer's. And those people ended up getting into trials, and they probably confounded the results of the trials because it really was a mixed group. And I've already mentioned depression. There are other medical conditions and neurological conditions, frontotemporal dementia, supranuclear palsy, Lewy body disease. There are a variety of neurodegenerative disorders. So can you enhance cognition in individuals that range from all of you, a normal population, to individuals with mild cognitive impairment? So these are the three originally approved drugs for the treatment of Alzheimer's disease. A fourth one, a different class of drugs was approved. And recently, there have been newer agents that have been approved by the FDA for the treatment of Alzheimer's disease, not without their side effects, but the data at least seems promising. So when I was at the University of Miami, we had a program in our center, Aging, bringing in super old people and training them on computers. Because we wanted to dispel the notion that just because you're 85 doesn't mean you can't use your iPad or iPhone or your laptop. This woman was a star, let me tell you, amazing. She was 102 incidentally. So there are a number of these available online. Any of you can, they're all free. You can sign up for them. And you know, some people find it really cool. I personally do the New York Times crossword puzzle every day. I feel like that staves it off a little bit. So it gets to the question of successful aging. You know, I don't know what the right term is. Healthy aging, optimal aging, aging well. There's really no great definition for it, but I think we could all agree it involves physical and functional health, cognitive health, emotional well-being, and social well-being. it's the ability to try to adapt and make the most with what you have. You know, I'm just not going to run a marathon. It ain't happening. Okay, I'm sort of resigned to that. It's okay. But I am not willing to give up certain other things that I do. And you got to work at that. So you have to decide what you're going to optimize. And this seems like a really good place to do that because you have a lot of opportunities. And the total absence of chronic illness or physical disability is not required for successful aging. There are a number of things that one can do regardless of how disabled you might be. It's really important. I have an 82-year-old patient I talked to today. She's really having a tough time. And she said to me, literally in our Zoom call, and I've taken care of her for 28 years, this woman was a star. I mean, remarkable, incredibly bright, 82 years old, and she said, I'm not a cane person. But what do you mean? She goes, I'm not wearing a damn cane. I said, you told me that you fell twice in the last week. What are you thinking? I know, but I mean, you know, that's not who I am. Well, it is actually now. Right? It is. Like, get a grip here. You know, challenging activities are good for you. Computerized games is one of them. Obviously, a healthy diet, physical exercise, stress management, and sleep is really important. If you're not sleeping, everything goes to hell. Because if you're not sleeping, you have more inflammation in your body, which is bad for everything. If you're not sleeping, you're not rested. If you're not sleeping, you're not firing on all cylinders. So if you're not sleeping, you need to have it evaluated. Are you not sleeping because you have sleep apnea, right? And if you have sleep apnea, you're not getting enough oxygen in your brain, you're not really thinking clearly, and your sleep has gone to hell in a handbasket. And the new CPAP machines are great, but you got to be evaluated, right? Very important. I can't overemphasize the importance of relationships, because this is the legal tender that keeps us going. Nothing is more important to me than my friends. I think I like fly fishing a lot. I'm going to Patagonia next in about 3 weeks. Go trout fishing. But more importantly are the 7 friends of mine that are joining me, because I love them. And I've known them, and we're going to share our recent experiences. And you know what we'll do? We'll talk about what medicines we're on and who our doctors are and all that other bullshit that we talk about. But it's the key. And loneliness and isolation is the killer here. I can't emphasize enough how important it is to maintain your relationships. Yes, exercise, diet, interesting activities, learn to do something new. Now, what happens, as you see here, is that, number one, if you haven't figured it out, women outlive men. Okay, so that's why 72% of men over 65 are living with a spouse, but only 42% of women are. You can interpret that a few ways. One is that the men died. The other is the women wised up and realized, I don't really need this. Okay. So talking about vision, this is important because the hardest thing I ever have to do is to tell a patient that I'm taking their car keys away. It's really, really hard. It's hard for them, obviously, and it's hard for me. And so there are, driving simulators. And what I do is the patients, no, you're not, particularly men, no, you're not taking my car keys. Yeah, I am actually. Okay, I tell you what, if you go to the driving simulation test and you pass, I'll let you continue to drive. They never pass. Never, not a single time. But it's difficult. Part of this can be a dementing illness, getting lost, and that happens, but also it's about vision. And when I tell patients who are not having any cognitive difficulty, don't drive at night. Driving at night's hard, right? Really hard. So those are the reasons why there are changes in vision. And then I want to talk a little bit about cognitive abilities. So this is a measurement between ages 25 and 85 related to different kinds of cognitive abilities. So if you look at the perceptual speed, it's the one area that goes pretty far down, and the other is numeric ability. So this is perceptual speed in the upper left-hand corner. It's like the worst pointer in mankind. I can hardly see it. I know you can't see it. But up here in the upper left-hand corner is perceptual speed. So, when you're 25, it's really good. Look what happens over time. For most of these other cognitive functions, spatial orientation, verbal ability, you sort of peak around 60, and then some of them fall off faster than others. So there's a difference between what's called crystallized ability and fluid ability. Okay? Crystallized abilities are the end products of information processing. It's things like vocabulary, general information, and the other kind of, and those are things that you acquire in your peer group, and then you know them, and that you are able to send a fax or know the password to the computer, although I'm constantly forgetting that. Crystallized abilities do not change over time. They don't. In fact, if anything, they get a little better as you get older. But look at the variability. There's a lot of variability in different cognitive functions among individuals in the 20-year group and in the 60 to 80-year-old group. Fluid ability is different. Fluid ability is the ability to solve novel problems that you've never accounted before. And an example of that would be if I said to you, the copier is not working. Could you take it apart and figure out how to fix it? No, I couldn't possibly do that. And fluid ability does decline over time. But, we have to know our own limitations. So let me conclude. We're living longer, and we will continue to live longer. And there is a tremendous amount of potential for a better mental and physical fitness in old age. Have you ever wondered why 65 was picked as the number? Because when it was picked, the average life expectancy in the United States was about 50. So they figured, oh, well, we'll just pick 65. I find that particularly insulting, right? Like, why is it 65 and not 75, right? I think we need a movement here. There is a lot of evidence that the old brain is capable of cognitive reserve and of learning. And we need to continue doing research in this area. So I've bored you long enough. I'm going to stop and want to thank you for inviting me.
slide with the suicide rates. It showed a decline on both lines in around 2000, 2001. Do you have any idea of why that would have occurred?
But good eye. Yes, so we had a number of campaigns funded by the National Institute of Mental Health, particularly directed to men, because men were never good at getting treatment for depression, seeking depression. They were very reluctant to be seen. We also were educating primary care doctors about suicide, because remember, most people with depression don't go to a psychiatrist, they go to their primary care doctor. So all those programs eventually were disbanded. So suicide rates started to climb. There was a very short hiatus during COVID where suicide rates declined, and now they've come back with a vengeance. The particular concern are the 15 to 24 age group and the 46 to 54 age group. But we've been pretty much stuck at 50,000 a year.
Thanks.
Yes, sir.
In the slide about halfway through, you showed 4 images of a brain with increasing tau and that. If those were images, where did they come from, or were they slides from
They
cadavers?
were post-mortem slabs, yeah.
We're reading now about environmental, if not causes, supporters of the development of Alzheimer's. Have we come to any good feelings or strong feelings about that? Or is it also, well, that's what they say, that was that particular study, but we haven't had it replicated or whatever?
So the cause of Alzheimer's disease it remains very obscure. First, let me just say there is a genetic form of Alzheimer's disease, but that accounts for a very small percentage of people with Alzheimer's disease, so-called familial Alzheimer's disease. For sort of run-of-the-mill garden variety Alzheimer's disease, there are several theories about etiology. One is viral, and there is some evidence that individuals that were infected with herpes simplex or other viruses may be more vulnerable for Alzheimer's disease or not. And there are a couple of very interesting and tantalizing findings. One of which is that men who were diagnosed with bladder cancer and were treated with what's called BCG directly into their bladder have a rate of Alzheimer's disease about 0. Now, BCG is a vaccine given outside the United States, but not in the United States, and there's never been a study looking at that vaccine. But this data about BCG is impressive, and now it turns out that if you've been vaccinated for shingles and 3 other vaccines, DPT and 2 others, that you also have reduced evidence for Alzheimer's disease. So what the mechanism of that might be is pretty unclear. The environmental issue has been driven largely by the Parkinson's literature. There's now evidence that, more and more evidence, that Parkinson's disease may in part be due to environmental pollutants. And if not necessary, sufficient to increase your risk. So I think we're pouring tons of money into Alzheimer's research. The state legislature has just voted to give us $3 billion in the state of Texas to create this depression prevention network. And that's $300 million a year for 10 years. We're all going to be competing for this, all of the Texas medical schools. because we really want to make breakthroughs in this area. But to answer your question, I wish I knew. Sure.
Yeah, just want to get your thoughts on EMDR. It's proven really good with PTSD, and I'm just wondering the impact it might have on depression and/or maybe Alzheimer's.
Yeah, well, you're going to have to get me back here to talk about that. No.
Okay, come back.
EMDR has some efficacy in post-traumatic stress disorder. It's, I would say, rated as mild to moderate at best. It certainly does not result in remission of post-traumatic stress disorder. It can be combined with other treatments, psychotherapies, and medication, for example. It's never been studied in depression or Alzheimer's disease.
Well, there's one interesting note in the graphs, and I've seen this before. You noted that in 1900, there were relatively few older people, but here's the key. 25% of babies died before they were 1, and many others went down with whooping cough, diphtheria, and everything like that. And those that made it past it were often able to live quite a bit longer than on the average than that if they could get past those. And here's the key: in 1950, well, only 3% died before they were 1, so you see, more could live past that. But here's another key thing. If it just stayed the same rate as 1900, only about 39% would be alive now, if it stayed the same rate. But in 1950, 93 or 94%, sure, it's improved some. Now we have 100%, a little higher, but you see something happened in that period that was significant.
Well, you know, in spite of our current Secretary of HHS, who seems to want to stamp out all vaccines, the fact is the matter that we eliminated measles in the United States, and now it's back with a vengeance, and children are dying because of it. And now he's talking about removing DPT vaccine. There has been a loss of scientific credibility in America, and now we're paying the price. So you're absolutely right about the average age, and certainly maternal mortality was extremely high back in the day before the development of modern antibiotics. So, point well taken.
Can you talk about early diagnosis of dementia, of Alzheimer's?
Sure. So there are very good neuropsychological tests that can pick up on cognitive changes pretty early. You know, we have a comprehensive memory center at Dell Medical School, which is staffed by neurology and psychiatry and neuropsychology. And so what I do for all of my patients is I have them go through this very all-day neuropsychological testing. It's pretty intense. It tests mood, depression, cognition with various very well-validated tests. That's really the first step. There's some simple screening tools like the mini mental state exam and the MoCA, the Montreal cognitive test that can be done, you know, by primary care. If you score 100 on those tests, doesn't mean that you don't have an issue, but you can feel reasonably good. And you want this to be caught before you're clearly having very significant functional decline. But yeah, relatively easy. And now there are blood tests that could help with the diagnosis of Alzheimer's disease. And some third-party payers are paying for those tests. There are also genetic tests that you can take to see if you are at genetic risk for Alzheimer's disease. There's a gene called ApoE4 and if you inherited ApoE4 from both of your parents, you have an increased risk to develop Alzheimer's disease. Doesn't mean you're going to have it, but it means you're at increased risk.
I have a question on something called the afternoon nap. If one does not get all the sleep you think you need, or you're up a couple times, I think the nap is a good opportunity to refresh. What are your thoughts?
Yeah, so I love afternoon naps myself. I don't have a chance to get them very often, but occasionally on a weekend I might do that. The biggest issue with afternoon naps is it can disrupt your sleep at night. And so when my patients tell me they have insomnia, and then the first question I ask after, do you have difficulty falling asleep? Are you waking up during the night? The next question is, are you taking afternoon naps? If the answer is yes, I say that kills your sleep at night. So afternoon naps are great, generally really small naps, like 30 minutes, 45 minutes maybe. 2 hours of sleep during the day, forget it. You're not going to sleep that night. And as we get older, we do tend to have more trouble with sleep.
We'll take one more question and then we'll close it out.
You said that older people have the ability to make neurons, and then also it's clear that you shouldn't drive at night. There are other things that are measurable that are declined. So is that some contradiction?
So, so when I was in medical school, we were taught that the brain, what you have is what you're going to have, and it's not going to ever repair itself. So if you had a stroke, you lost those neurons. And then, remarkably, we discovered that there were 3 or 4 regions of the brain that are making about 3,000 to 5,000 new neurons every day. And in particular, in this brain region associated with learning and memory, which I thought was like a great finding and should make all of us feel good, right? It's probably the reason why, no matter how old you are, you could learn new things. As far as the driving thing goes, I largely was speaking about that relative to visual issues, right? Because it's easier to drive during the day than at night. And the glare is more difficult, and if you have cataracts, that makes it even worse. So I don't want to take anybody's keys away if they're capable of driving, right? But I do want to avoid, unforeseen accidents.
Before thanking you, Dr. Nemeroff, I wanted to make 2 announcements. One is later in the year, we'll be having somebody from the Malva Clinic present to us, Alyssa Guire, who's the Director of Transformative Services, I think is what it's called. And the next session, 2 weeks from now, Bill Schwartz will be back to give us our second lecture on aging, on sleep, and this time it's sleep when aging.
Oh yeah, but he'll answer your question.
Yeah. And we'd really like to thank you.
Thank you.
Excellent.
Thank you.